Welcome to the conference session titled Inherited Bone Marrow Failure Syndromes. Thank you for joining us today. My name is Nikki Ashadu, and I'm the Program Content Manager at AMDSIF. As we get started, AMDSIF would like to recognize the generosity of our corporate sponsors, Diamond Level sponsors Alexion and Novartis, Gold Level sponsors Apellis and Genentech, and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. When asking questions, please wait for the microphone so everyone can hear the question you are asking. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Paibel Aguayo-Hiraldo. At the Children's Hospital of Los Angeles, Dr. Aguayo-Hiraldo is the Medical Director, Transplant and Cellular Therapy Section, Director, Advanced Fellowship, Transplant and Cellular Therapy Cancer and Blood Disease Institute, attending physician for transplantation and cellular therapy, hematology, oncology, and assistant professor of clinical pediatrics at the Keck School of Medicine of USC. Her clinical interests include stem cell transplant for non-malignant disorders and the management of and reduction of post-transplant toxicity, specifically graft versus host disease and the transplant-associated thrombotic microangiopathy. With that said, it is my pleasure to welcome Dr. Aguayo-Hiraldo.
Thank you so much for that kind introduction. Can you hear me through the microphone? A little bit more? Better. Perfect. Something up here. Thank you so much for the organizer for inviting me here for this meeting. Thank you for the patients and family that are here. It is truly my honor to be here with you today. We're going to be talking about inherited bone marrow failure disorders. So you have heard about MDS, PNH, aplastic anemia. We're going to be talking a little bit more about the most common bone marrow failure disorder that present typically in childhood. I am a pediatric bone marrow transplant doctor, but also because this syndrome not only causes bone marrow failure, but many other organs are affected and they are seen through life, not only in the pediatric time. So as a brief overview and knowing that there are doctors and families patient here, we're just going to talk about, I'm sure you know, all of you, the bone marrow is a soft, spongy tissue found in the center of most bone. It contains the hematopoietic stem cells. So those cells are the ones that are giving rise to your red cells, your white cells, and your platelets. So that helps you carrying oxygen to your organs, prevent bleeding, promote clotting, and prevent infections or fight infections when you have an infection. Absence of a bone marrow or absence of those hematopoietic stem cells can be fatal. Bone marrow failure is a decreased production of either of those three main cells, the progenitors for the white cells, the platelets of the red blood cells. It can be a diminished cell count, or it can be completely absent, and it can be 1, 2, or 3 cytopenias present. The inherit bone marrow failures, these patients are born with either a mutation or a change in their bone marrow that prevents them or have impaired the ability of the bone marrow to produce these healthy cells. It is a heterogeneous presentation. Many patients can present with either 1, 2, or 3 cell lines down, but also with other organs affected with this bone marrow failure. And one thing that is commonly seen in most of these inherited bone marrow failure disorders is like they have predisposition to develop MDS, AML or acute myelogenous leukemia, or solid organ cancers in the future. They're usually associated not only with the bone marrow failure, but many of them has also congenital or physical changes that you can see in the infants or child as they grow. The most common syndrome that we're going to be talking about today include Fanconi anemia, dyskeratosis congenita, Diamond-Blackfan anemia, Shwachman-Diamond, and GATA2 mutation, among others. One of the things that I don't think the pointer is looking, but the bottom part of the slide, we're looking at these diseases. So the Fanconi anemia, dyskeratosis congenita, these two generally will present with aplastic anemia. So most of them will have all 3 cell lines down upon presentation. So they mean they will be presenting with anemia, low platelets, and low white blood cells. When you look at the Shwachman-Diamond, usually they present with most of a neutropenia. So the white blood cell count tends to be the first line to be down. So this patient will present with infections, low white blood cells. However, eventually they may develop or they will develop bone marrow failure. The Diamond-Blackfan, the fourth one in the farther left, they present with red cell aplasia. So usually anemia, but further down the road, they will present with a complete aplastic marrow or bone marrow failure. GATA2 mutation, it's a little bit less common. They present with decreased white blood cells, more opportunistic infections. One of the things that is common is that all of them increases your risk or increases the risk of that patient to eventually develop MDS or AML. And in terms of that is in the malignant hematology part, the solid organ or the oncology risk in Fanconi anemia, these patients eventually, when they do develop, if they develop cancer, it's usually in the squamous cell carcinoma, head and neck. For this keratosis congenita, it's very similar, squamous cell carcinoma, head and neck. For Schwagman diamond, we do not have established solid cancer that tends to be, solid organ cancer that tends to be most common. But in diamond blackfan, they develop early colon cancer or osteosarcoma. And in the GATA2 mutation, we have EBV or virus-related oncologic tumors later on. The first one we're going to talk about is Fanconi anemia, and this is a DNA repair disorder. So what happens every time these patients, these cells are exposed to infections, chemotherapy, and we're going to talk a little bit more about that, they are unable to repair the damage to those cells. And it's what causes the damage down the road. It is a rare multisystemic disorder affecting the bone marrow function at the beginning. Genetic causes is one of more than 23 genes at the moment. Most of them are, you have to have, it's autosomal recessive. There are some of them that are autosomal dominant, only one of them. And there's one of them that's also X-linked. But for the most part, this patient needs one gene coming from each one of their parents, and certain mutations carries different risk. Presentation, this patient will present early in their infancy with low white blood cell count. Therefore, they present either with the white blood cell count that is low on CBC, or they present with multiple infections that send the doctors then to check the blood counts. They have bleeding and they have bruising because the platelets are down in their counts. They do have skeletal and skin changes. Fanconi anemia tends to have differences in their hands, minimum in the fingers. Sometimes they have either hypoplastic or small fingers, or they have the AMSAT thumb. So you can see these patients very early on, just in physical presentation before they present with the cytopenias. They can have genitourinary changes, including their kidneys, and infertility longer down the road. They do present with endocrinopathies, so adrenal insufficiency, diabetes, dyslipidemia. Usually we see this after the adolescent period or in adulthood. They do have increased malignancy risk. And when we talk about the autosomal recessive, most of these genes, one of the ones that I present here, the FANC-D1, these genes, because it's associated with the BRCA, even with a heterozygous, so meaning this patient may have only received one gene from one of their parents, they still have the increased risk of breast cancer and solid organ cancers down the road. Their incidence of MDS and AML can be as much as 700 higher than the general population without this gene. However, we have seen a decrease in this because most of these patients will undergo bone marrow transplant early on before the development of MDS or AML. Solid tumor, squamous cell cancer in the skin and neck, it is not prevented by undergoing hematopoietic stem cell transplant. We can only fix the hematopoietic bone marrow failure, but we cannot fix the cancer predisposition. And the treatment we use for bone marrow transplant can also actually increase some of this risk depending on the chemotherapy that we use to treat these patients. They do have increased sensitivities because it's a DNA repair syndrome. They have increased sensitivities to specific chemotherapies more than others. So that is something that we take into consideration when we meet this patient and we plan their bone marrow transplant. The diagnosis, because we know it's a DNA repair syndrome, we do a chromosomal fragility test. Most of us will do the DNA, if the patient has physical changes consistent with Fanconi, we do the chromosomal fragility test along with the genetic testing. So we have both the evidence that there's chromosomal changes, but also what specific mutations they have, because that mutation can tell us risk down the road for future cancers. Treatment options for initially we do supportive care. We want to do supportive care for the anemia with blood transfusion, platelet transfusion for thrombocytopenia. We do growth factors to prevent infection, but only when the counts are significantly low. There is, previous to bone marrow transplant, there is plenty of data using androgenic steroids, most commonly danazol. This has shown to improve the platelets and the hemoglobin. However, it is something that you have to be chronically in, and it will not fix or cure completely your bone marrow failure. It does not prevent progression to MDS or AML in these patients. L-Thrombopac, it's something that it stimulates the bone marrow, usually the megakaryocyte, which is what makes your platelets, but it also improves all three cytopenias. So we see an improvement in the white blood cells, the red cells, and the platelets. However, again, it does not prevent progression to MDS and AML. Gene therapy is only available for one of the genotypes. It is the most common genotype, the FAA, but we only have limited experience with the gene therapy, and it's only done under clinical trials. The bone marrow transplantation is the only cure for the bone marrow failure part, as well as the MDS and AML. It is indicated for those patients that have at least moderate to severe cytopenia, or it can be offered to a patient who has moderate cytopenia, but we have a matched sibling donor, which is the gold standard donor that we like to use for these patients. It is considered early because the outcomes are improved when we do the bone marrow transplant early, before there's MDS, before there is AML on these patients. The match-related donor for many years has been the gold standard patients. During the past decades, we improve our supportive care, so we can do transplant with match-unrelated donor and haploidentical, so a donor that is half match. And as a pediatrician, for me, that means that most of my patients have at least one parent alive that I could potentially use as a donor. However, the outcomes are still better with a matched sibling donor. As you can see here, it's about 80 to 90% if we transplant these patients before the development of myelodysplastic syndrome, before the development of AML. And that was improved for about 50% survival in the early 2000s. And this is thanks to supportive care, improvement in graft versus host disease, and all the transplant-related morbidity and mortality. If you transplant these patients after MDS and AML had developed, the survival goes between 30 and 55%. That range is usually because the papers, some of them include early 2000, and now after 2010, the survival has improved. However, it's significantly less after you develop MDS or AML. It is still a cancer predisposition syndrome. So while I can fix the bone marrow failure in these patients, I cannot prevent the risk that they have for solid organ and skin and head cancer. One of the things we take into consideration to decrease that risk is I try to pick chemotherapies to prepare them for the bone marrow transplant that are not alkylating or do not damage the DNA as much to increase the risk of cancer. However, I cannot prevent that in these patients. The most important things for that, and there's something that we mention to our patients the moment we meet them for bone marrow transplant, is like they will need lifelong monitoring. It is very important for these patients to avoid things that will increase your risk of cancer, smoking, sun exposure, and to do your cancer screening at the age appropriate, mostly for this patient, even though, for example, for the general population without genetic profile, the breast cancer screening for women might start at the 4th or 5th decade. For these patients, will start earlier. And that's something that we remind the patients. Your cancer screening is a lifelong, very important part of your treatment. As you can see, I am a pediatrician, so I'm a little bit biased about talking about kids, but Fanconi anemia affects these patients for the lifelong. Initially, we will see the anatomical anomalies because the thumb is one of the main things that we see in Fanconi anemia. We usually surgically change that so that they can have they're able to have the opposing thumb and can go to school and write. Even though we don't write anymore in school, maybe they use keyboard and computers, but it's still a very important part of your day-to-day. So that's one of the first things that we improve in pediatrics. We do recommend going to bone marrow transplant if the patient has a donor and the patient's organ function can tolerate the bone marrow transplant early on. And we put that box between pediatrics and adolescent because it's before we want to do it before the MDS or AML present. Androgens and growth factor are still there, but it's a lifelong and do not fix or cure the problem itself. There is the ex vivo autologous cell gene therapy with a question mark because it's only available for one of the genes, and we don't have prolonged data many years after the gene therapy. Once you get to AML and MDS, and I know you have discussed some of the MDS treatment options early on, and you will hear more about it later on. Allogeneic stem cell transplant is still an option for this patient. However, the survival is diminished, so we want to do it before the myeloid malignancy present. And the solid tumor, the most important thing for us is screening and monitor that. We cannot prevent that cancer predisposition, but we can screen, we can diagnose early, so this patient has the best chance at cure, at treating those solid cancer early on. there is infertility and gonadal failure. There's not only they can have delay pubertal age for this patient, but also they can have premature menopause. So infertility and counseling is very important as these patients grow out of the adolescent into the young adulthood. And endocrine management is something that they have to do for life because of that risk of dyslipidemia, diabetes, therefore cardiac risk, metabolic syndrome is an issue for these patients. The difference in treatment, which is something that I've mentioned, there is a significant kind of dichotomy between treating patients with Fanconi early in the pediatric age versus treating patients in the adolescent and young adults, because the survival is so good in the pediatrics. If the patient's organ function can tolerate a bone marrow transplant, we will recommend a bone marrow transplant for these patients and only use this androgen, metformin. Metformin right now, it's a medication that you use for diabetes, but there has been some clinical trials using for Fanconi anemia. However, the published data only have about 3 years of follow-up on those patients. And what it showed, improvement in the counts, decreased need for transfusion. We don't know the long-term of this medication, and there's an active clinical trial for that right now. We do only use these drugs in the pediatric patient as a bridge to bone marrow transplant. If that patient has a donor and we can move to transplant, that will be our recommendation because the survival is so high, between 80 and 90%. However, in the adults, the survival, as we spoke, is between 30 and 55%. And even though it is improving as years go by without improved supportive care, the chances of transplant-related mortalities are higher. So in these patients, we do consider more long-term androgens, L-Thrombopac, and metformin. If we do move to transplant with this patient, it's even more important to pick reduced dose, reduced intensity, that RIC, reduced intensity conditioning, and reduced dose of those alkylating agents if we have to use it for this patient to reduce the transplant-related morbidity and mortality. And we monitor for malignancy. For Fanconi anemia, it's earlier and more frequent that we do the monitoring for cancers. Dermatology, they should be seen by dermatology twice a year, just monitor for skin cancer. We want oral cavity evaluation, not only for oral health, for the regular oral health, for looking for lesions in the mouth that we can biopsy and treat. Gynecological exam is very important. MRI for breast cancer starts as early as age 20, depending the FANC mutation that those patients have. The same with colonoscopy and endoscopy. We want to look at GI tract and look for either esophageal, stomach, colon cancer very early on and frequent in these patients. Moving to the second one, this keratosis congenita, also a disease that is most of the time diagnosed in kids. It is a telomere biology disorder. I forgot to put the picture, but telomeres are like caps at the ends of your chromosome that protect that chromosome every time there are cell division. You and I, all of us are born with a set length of that telomere. Let's say we can start with 11K kilobases, 11,000 of those bases that covers your chromosome. These keratosis congenita have about 5% of that. They start very low, and the rate of progression, telomeres are our biological clock. Every year they decrease a little bit, but if you have a long telomere, those chromosomes are protected. In this keratosis congenita, these telomeres start short, and the rate of reduction or shortening is double the rate of patients without these keratosis congenita genes. Presentation, as you can see in the far right, they usually have changes in their nail, very marked kind of waves in their nails, what we call these plastic nails, are very prominent after the first 5 or 7 years of life, but it can be prominent early on. They have leukoplakia, these white patches in the tongue that are not able, they cannot wash out, and they have hypo and hyperpigmentation patches in the skin. The most important thing is that they do present with bone marrow failure. 80% of them will have bone marrow failure by age 30. Extramedullary disease, as you can see here, is about 11% by age 10, but by age 20, up to 50% of the patient will have pulmonary fibrosis. Liver fibrosis also happen with this patient, up to 75% in the second decade of life. So it's a disease that has very severe complications early on in the young adulthood. Genetic causes are DKC, TERC-C, and TERT is the most common causes genetic. And while it's uncommon, it's 1 in 1 million persons that have this disease. When we see bone marrow failure and new onset bone marrow failure in that adolescent range, 2 to 5% of patients will have a gene in the keratosis congenita family. What I wanted to show here is the natural history. So in the first one is the cumulative incidence of bone marrow failures. In the y-axis, the lower, we're looking at ages up to 20 and 30. So as you can see, this is early in life. Up to 100% of the patient will have bone marrow failure. The second middle one is the cutaneous manifestation. They usually start early on. However, not everybody has to have that clinical mucosal manifestation. If you see at the bottom, we're looking at liver fibrosis, pulmonary fibrosis, and the overall survival. So this patient has a very severe complication in the lungs and the liver that unfortunately lead to early death, usually by the third or fourth decade of life. The treatment option, monitoring. While monitoring doesn't sound like a treatment for this patient, is very important because we can diagnose and treat complication of this disease. We want to monitor the counts of these patients, and the most important thing is, like, similar to Fanconi anemia, these patients are candidate for a bone marrow transplant, but it will be better done if we do it before they develop MDS or AML. The frequency of this monitoring depends how low the counts are at the beginning and how that bone marrow looks when we do the bone marrow biopsy. We can use growth factor. However, this is a disease with increased risk for AML and MDS. So we tend to use growth factor, the GCSF, the one that increases your white blood cell, only in the setting of infections or very severely low neutropenia. Anabolic androgenic steroids, similar to the one we use for Fanconi, can be used for pulmonary fibrosis. However, the clinical trials, some of them have shown that it's improvement or at least slowing of the progression. However, other clinical trials were not as positive. There is a new clinical trial going on looking at if, starting from the baseline that we may not prevent the fibrosis, is trying to slow down the progression in this patient. So it's a clinical trial that we're very excited about. And if unable to undergo transplant, that is an option to try because it does increase your counts. It does decrease your need for transfusions, for blood transfusion and platelet transfusion. The role of bone marrow transplant, it is the only curative option. However, is the only cure is for the bone marrow. Similar to Fanconi, we cannot prevent the cancer predisposition syndrome. As you can see, as the years have gone by, initially we started treating these patients 20 years ago with the same bone marrow transplant that we were using for other bone marrow failures. However, when we use what we call myeloablatives, so heavy drugs, alkylator-based, the strongest chemotherapy that we have, the survival was only 30% at 10 years. We have reduced the intensity of this chemotherapy. Now we have about a 70% survival, and the newer clinical trial, the alkylator-free treatment that clinical trial just close to accrual. We enrolled 40 patients. The first 13 patients that we saw about 100% survival in some disorders. It's only included dyskeratosis congenita, and that's why the survival changed. But the survival has been looking good. And not only the survival, this patient has less complications during transplant. So we also, the other thing that we want to see this, we not only want these patients to survive transplant, we want to reduce the chance that my chemotherapy, my therapy that I give for them to transplant does not increase furthermore the risk for further complications, pulmonary fibrosis, liver fibrosis, and secondary cancers. Moving on to one that is a little bit less common, Shwachman-Diamond disorder. It is a disorder that presents with neutropenia, but also pancreatic insufficiency. Sometimes this patient can present with either dose of two, so it can be increased infections in infancy or early childhood, or they can present with the exocrine pancreatic insufficiency. So you have fatty stools because they cannot absorb the fat in their diet, and they do have bone abnormalities. The genetic causes, I'm adding the gene here, most of the time it's an SBDS gene, 90% of the time. There are other less common mutation like the SRP54 that is also associated with even earlier onset of bone marrow failure in these patients. Treatment option supportive, you will give the pancreatic enzymes, you will give the growth factor, but only for severe neutropenia, because similar to Fanconi and dyskeratosis congenita, these patients also have increased risk of MDS and AML, and there's a risk that we consider. Some researchers call it theoretical risk, but there's still a risk that we can increase the risk of MDS later on with growth factors. So only in the setting of infection or when your neutropenia is less than 200 to 500 and that neutrophil count. Supportive care and the role of bone marrow transplant. We offer bone marrow transplant when these patients are moving towards the bone marrow failure. And I like this table because it tells kind of the surveillance, how important this monitoring is for this patient. The goal for us to monitor this patient is to identify early either changes in their cytopenia, changes that let me know this patient is moving on to either bone marrow failure or MDS. So I'm looking to falling blood counts, but in the setting of a cellularity in the marrow that is increasing. I'm looking for changes or dysplasia in the bone marrow, cells that are no longer looking completely normal. a look at expanding clone. You learn about PNH clone. We look to clones in other genes and other cellular, but we see not only that, similar to PNH, we look not only at the presence of the clone, but is this clone expanding? Is this clone getting higher? And high-risk cytogenetic. We know we have learned that in this patient-specific cytogenetic, like 7q deletion, differences in this karyotype can increase the risk of these patients develop NDS or MMA even early on. So this is the lower table is mostly kind of the frequency that we do for these patients. A complete blood count can let you know about the cells dropping. The patients need a transfusion, but it's not sufficient to let you know what the bone marrow is doing. So in these patients, we not only do blood counts in the blood, we do bone marrows in these patients, and depending the difference and the dysplasia, the abnormal cells that we see in that marrow, it is usually recommended to do every 12 months, but however, in patients, usually kids, because I'm a pediatrician, when we see dysplasia or changes in that marrow, we will repeat more frequently depending how different those changes are. Diamond-back fan, and even different than trauma, they present with residual aplasia. So these patients will present with anemia early on, and again, it's a cancer predisposition syndrome. Usually, they will have anemia before 1 year of age, very early on, very severe anemia, needing transfusion. They have reduced reticulocytes, and the normal is that they have normal platelets and normal white blood cell count. So it's usually purely an anemia problem at the beginning, and then they progress to bone marrow failure. They also have changes clinically, so their faces look different. They have cleft lip or cleft palate. They can have microcephaly. They can have short neck, musculoskeletal changes. That's my timer, so I'm going to move on to the next one. The difference to the other ones, this disease can respond to steroids. And this disease, 80% of the patients will respond to steroids. However, up to 25% of the patient will require steroids for life. And as we heard before, steroids can have, we talk about avascular necrosis, we talk about another diseases. So usually, as a pediatrician, we usually start these steroids after the first years of life because I don't want to affect the growth of this patient. We start with high doses, 2 milligrams per kilo, at least a 4-week minimum, and we monitor for complications. After, like similar to what we were talking about aplastic anemia, we like to get rid of steroids if we can. So after that 4 weeks of high dose steroids, we try to wean them off steroids. Some patients will go on to continue to be responders. And by responder, I mean at least a hemoglobin of 9. It's a little bit less than the PNH that we were talking before, but at least not dependent on transfusion. But again, some patients don't respond to that for a long time. Chronic transfusion, we use initial for stabilization. So definitely that first years of life to avoid the use of steroids early on, and those not responding to steroid. It is unfortunately one of the major causes of mortality in this patient because of the iron deposition in the organs overload. And we want to use it as minimal as possible if we're going to move on with transplant for these patients. It is the only definite treatment, talking about bone marrow transplant, for the hematologic manifestation. The survival is between 70 to 90%, depending on the donor source. And we know that matched sibling donors and transplanting patients before age 9 have the best outcome. However, we still try steroids because it has a high, and the pediatric population, they do respond very well to this treatment. This is, again, a table, and I think I'm running out of time, but I don't see the timer. But again, similar to the Fanconi dyskeratosis congenita, we look at this patient because of the cancer predisposition, they need lifelong monitoring. We look, if patients are going on steroid, we need to monitor for infections. We want to do ophthalmology exam. They can have glaucoma, they can develop cataracts. We're gonna see that this response to steroids, not only the hemoglobin, but that reticulocyte count to make sure that they're in fact responding well to steroids. Because they're on long-term steroid, we're concerned with metabolic syndrome, diabetes, overweight. So we want to monitor the blood pressure, BMI, dental review. And down the road, if those patients continue on steroids, like we talked initially earlier on about avascular necrosis, long-term steroids can affect your bones. So DEXA scan, bone density, metal panel. And then as years go by, once they hit adulthood, we want to do the cancer screening with a cervical smear in woman, breast screening in cancer in woman, and bone marrow to assess cellularity about every 5 years. Thank you so much. Okay. The next one we're going to talk is severe congenital neutropenia. It is an isolated severe neutropenia in the neonatal period. It is present with a heterogeneous presentation, but usually recurrent deep-seated bacterial infections, pneumonia, abscesses, omphalitis, there's infection in the umbilical cord, pneumonia in these patients. It is again heterozygous mutation in Elaine and X-linked and other new mutations that we've been recognizing as the years go by. We do use growth factors similar to others, but only for severe neutropenia because most of these diseases have cancer predisposition syndrome, and we want to avoid that increased risk of MDS and AML. And we do supportive care as that with antibiotics for infections and prevention. Bone marrow transplant still offers the only curative option for this severe congenital neutropenia, but it will not, similar to the other, we cannot prevent the increased risk of developing MDS or NDL, AML, or solid organ cancer. The cumulative incidence of MDS and AML in these patients is about 21% by 10 years of age. Depending how early we transplant, we may be able to prevent that if there are no clones that are identified in that bone marrow of those patients. This is another one that is fairly rare. It's about 100 cases reported in the literature, and it's thrombocytopenia that's present at birth or in the neonatal period. This is a fairly dramatic presentation because most of the time this patient has no platelets that you can see in the CBC, and they can have brain bleeds or gastrointestinal bleeding at the moment of birth, or they are identified at the moment of death. 70% of them will have that severe neutropenia below 20,000, and it will cause petechial bleeding. But like I said before, the ones that we tend to see are the ones that come with a brain bleed, unfortunately, at the moment of decrease progresses to bone marrow aplasia, bone marrow failure, usually within the first 3 years of life. These patients, again, similar to the previous one, we want to monitor them to monitor for that progression in the bone marrow, progression in the drop-in or how severe the cytopenias are, and early going to transplant for these patients if the patient can tolerate and we have a donor. Genetic causes is again an autosomal recessive disorder. We do supportive care with transfusion, but we want to take these patients to transplant if we can as early as possible before they develop MDS, clone, or dysplasia in those cells. Similar to other, which is something that you will hear in all of these inherited bone marrow failure disorder, bone marrow transplant will only cure the bone marrow failure, but it will not prevent other organ damage or solid organ, solid skin cancer. The incidence of MDS, I mentioned that part. And I want to come about transplant outcome for this disease. Even though it is a rare disease, this paper is the largest cohort of KAMT patients that I've found, and they have a very overall survival rate of about 90%. And I think the farther right is not as clear, but we still prefer match-related or unrelated donor, and there's a significant survival. But our supportive care is improving as years go by in terms of unrelated and haploidentical transplants. So for these patients, we can still use an unrelated or mismatched donor. However, the outcomes is about 10 to 15% lower in terms of survival. This GATA2 mutation in pediatric is, we see it, but not as common as we see in adult. It is a germline immunodeficiency, and as a pediatrician, we tend to see that more as the immunodeficiency being the presenting sign. It used to be known or still known as monomax syndrome, and it's because of the monocytopenia. So the monocytes are the one that is significantly low, and they have increased risk of opportunistic infection. There's familial MDS, and Emberger syndrome seem to be the other name. We do not know the real prevalence in pediatric, but one of the things that we see is that most adolescents that present to us as an MDS with monosomy 7 as that the presenting sign, when we look at the cytogenetic, when we look at the genetic panel, they usually are GATA2 deficiency. So that's one of the parts that we see. If we don't see them with the immunodeficiency, we can meet those patients when they present with MDS in the adolescent years. If you don't present with MDS, they can present with persistent warts, monocytopenia, pulmonary alveolar proteinosis, which is something that I've seen very early on before age 5 years of age for these kids. Cytopenias that looks like bone marrow failure, so all of the counts drop, but patients can present just with MDS without having a preceding or at least a known cytopenia. They were seemingly normal, or they may not have had blood counts done previously, but they can be presented with MDS as the presenting syndrome. The treatment option, initially supportive care for infection if the presenting sign is immunodeficiency. However, monitoring is very important because these patients can progress to MDS and AML. Hematopoietic stem cell transplant is still the curative option for the bone marrow failure part of this syndrome. And as you can see, the survival has been improving. It's about 75%, match related, similar to other diseases, match related. It's better tolerated and better survival than unrelated and mismatched donor. However, this paper, it's at least 5 years old, so papers are usually a little bit delayed. We are seeing a little bit improved survival in terms of unmatched, unrelated mismatch or hypoidentical transplant. But however, if you can see in the bottom left in C, the transplant-related mortality, so it's not only the relapse, they have increased risk of GVHD, graft-versus-host disease, acute and chronic, and that is driving some of the mortality in these patients. With newer supportive therapy and newer graft-versus-host disease prophylaxis and treatment, we're improving the survival. So in patients, even if patients don't have a matched SIB, which is about 25% of the patient will have a matched SIB in their family, we can still transplant these patients with a relatively good survival. And we're working even more to decrease that bone marrow transplant-related morbidity and mortality, but increasing the supportive care or improving the supportive care so this patient can tolerate transplant. So as a summary, I cannot review most common bone marrow failure syndrome. I briefly discussed the presentations and treatment. I discussed outcomes and potential complication. And one of the important things that I like to drive home that is so important when I meet this patient for the first time, these patients, even though when I meet them, even if I'm going to offer the bone marrow transplant, or even if they're not candidate for because of the organ function or we don't have a donor, the lifestyle choices, healthy life choices are increasingly important. These patients will have increased risk of pulmonary fibrosis in the case of this keratosis congenita. They will have skin and head cancer. We have to decrease the smoking, decrease sun exposure. I talked to my patient about using long sleeve and big hats. We have to decrease the risk of even of that secondary cancer that they can have. It's even more important for all of us in the audience to do our cancer screening, but for these patients that have a cancer predisposition, that mammogram, colonoscopy, all of those cancer screening has to be religiously done because we know we cannot completely prevent these secondary cancers or secondary malignancy, but we can diagnose them early to give those patients a better chance of survival that cancer. And that will be all. Thank you so much for your attention. And I really like that quote from the AAMDS International Foundation about connection and how important it's just to connect with other patients and other family members that can be living through the same symptoms and conditions that patients have. And with that, I will answer any questions.
Thank you so much. Any questions? Oh, Dr. Paquette, hang on one second. Oh, here we go.
Why do androgens work for Fanconi's anemia? I understand why they work for telomerase defects, but why does it work for Fanconi's?
The mechanism of action of how it works in the pathway in the bone marrow, I have to get back at you of that. It has been, he has an answer that we see changes in the.
I don't have an answer. I just think I have a.
It's just because I just transplant them.
More question.
Yeah.
Right. So Fanconi's and other childhood bone marrow failure syndromes don't have the same clinical manifestations by the time they get to be adult, because probably they've been missed in childhood, but they can still have the same underlying gene mutations. More and more in younger patients, we send off these hereditary gene mutation panels and come back with variants of unknown significance, which may or may not have clinical relevance. And how is not a, I don't know of a rational way to interpret them, but I wonder if you have an algorithm or a way to, what you think of, because you're looking for a clinical syndrome, you're looking for short fifth digits, you're looking for other things that clue you, but we know that patients in adulthood cannot have any physical manifestations. What do you do?
Our
Variants of unknown significance.
Our center does not have specific algorithms, so but in patients that we encounter the variant, the unknown significance that we sometimes find in the gene panel, then we feel more strongly that you have then to support your diagnosis with everything else that the patient has. So either the bone marrow or the dysplasia, or sometimes I transplant patients up to 25 years old, but sometimes for me too, because if you don't prove to the insurance, which is the practical part, if you don't prove to the insurance that this patient needs a bone marrow transplant, you might not get it approved. However, we just give more chance. Maybe you have an unknown significance in your gene, but you still have bone marrow failure. So we still move towards just transplantable bone marrow failure. If there are other characteristics that hint towards this is a cancer predisposition syndrome, then that's still important for me because I want to pick the right chemotherapy. But then we give more weight to the other changes and characteristics we see.
You mentioned about use of haploidentical donors. How do you get around using post-transplant cyclophosphamide?
That is a great question. I work at a centers that we are more alpha depleted bone marrow transplant, so we don't use the cyclophosphamide, and there's an option for a reduced toxicity. So we remove the T cells before we infuse to the cells, so we don't need the post-transplant cyclophosphamide, or we don't need the tacrolimus or all of that. I think for PT side will be, yes, that's what we use for haploidentical transplant. We use PT-Cy, post-transplant cyclophosphamide, but usually only for leukemia patients. For non-malignant, we try to do the alpha-beta depletion, so that way you avoid the alkylating cyclophosphamide in those patients.
Really great talk. I just had a question. It seems like identifying these patients earlier, doing transplants earlier has been beneficial. As the cost of sequencing has gone down, do we ever see some of the sequencing being incorporated into newborn screening? And is that something that you see happening in the future?
That is a great question. I have not seen changes adding some of these diseases in many years. I've worked in at least 3 different states in the States, and I haven't seen this being changed. However, when I used to work in other state in Texas before, and we were doing, if you couldn't add it to the bone marrow screening, places that have global health kind of part to their hematology oncology program, they're doing kind of low cost testing for these things. I don't know if I can convince Congress to add it and every state to pay for adding them to immune to the newborn screening, but that will be a life-changing, because then you know when to start immediately following that bone marrow, because some of them in this keratosis congenita, you can have AML by age 10. So the earlier you diagnose, the better. I don't know about changes in the state dictated newborn screening soon. It will be great to have. Thank you.
Thank you, Dr. Aguayo-Hiraldo, for sharing your time and expertise with us.